Kavita. Thanks, Kavita. Good morning, everybody. What we are going to see today is the development of the human heart, and we are going to see an overview of overall steps in the development of the heart, picking up a little of every structure. Why is it important to understand the development of the heart? Because all the congenital heart diseases which we are going to deal with in the future are basically developmental errors, and these errors happen either because of a change in the genetic makeup or because of change in the environment. Change in the environment means that if the mother gets exposed to teratogens, or say if there is a change in the maternal environment like diabetes or presence of maternal antibodies or infectious agents, say like rubella. Genetic makeup can change if there is, say, a 22q11 deletion or heterotaxis, which are commonly known to be associated with a genetic issue, or it can be situations which are familial like Atrioventricular septal defects or ASDs, etc. Now this happens and hence it's important for us to understand the embryology of the heart, because whatever happens in terms of changes in the genetic pathway will be affecting the process of cardiac development, and hence it's important for all of us to know the embryology of the heart. Now before we go into it, two things which are so special about the heart is that it is the first system to function in embryo and it's the first organ to fully develop. That means structurally and functionally the heart is the first organ. Now when we think about the heart, it is going to be in terms of the development of different structures, the flow of blood inside the heart, and also the conduction system. So what we are going to see today in the short talk is a brief overview of the cardiac development. That means from which area it comes and what happens to the embryo during the process of cardiac development, and also then looking into the individual steps like the sidedness. Sidedness includes the atrial situs, the cardiac looping, that means the right ventricle on the right of left ventricle, the development of the atrial septum, the ventricular septum, and the atrioventricular canal, and then the last is conotruncal septation. We are not going to see in detail the systemic venous rhythm and also the aortic arch development. Just overall, we can see that the heart tubes are formed by 3 weeks, and by 4 weeks we have a loop which is called the cardiac loop, and by 7 weeks the heart is fully developed. So to understand an overview, we can see here this is a sagittal section of the embryo where this is the mesoderm, this is the procaudal plate. This is the amniotic cavity and this is the yolk sac. The splanchnopleuric mesoderm, which is lying initially cranial to the procaudal plate, is actually going to give rise to the heart in the future. This is the cardiogenic area. The cardiogenic area is initially situated on the dorsal aspect on the cephalad area, which after the folding of the embryo comes to migrate on the ventral aspect in the midline. So this is the cardiogenic area and it is derived from the splanchnopleuric mesoderm. To start with, there are two endothelial heart tubes, the right and the left, and this happens by 3 weeks of gestation, which over time partially fuses. The fusion typically happens throughout except on the caudal aspect. Over time, these tubes develop bulbous dilatations, and by 22 days, you have the dilatations developed and also the fusion which has happened on most of the part of the heart tubes. This is the caudal aspect, and this is what is called the sinus venosus. As we go above, this is the atrium, this is the ventricle, and this is called the bulbous cordus. The detailed subparts we will see few slides later. Now, we saw that the amniotic cavity is here initially, and this is the mesoderm, this is the splanchnopleuric mesoderm, and this is the yolk sac. So the yolk sac is going to give rise to the gut. Now after the folding of the embryo, we can see here, this is going to be the relationship. The foregut is here and the mesoderm is here. Now in the mesoderm, we can see that these are the two endothelial heart tubes, and this is the pericardial cavity. The endothelial heart tubes and the pericardial cavity are close to each other, and slowly these tubes invaginate the pericardial cavity. Because of which, at the end of folding, we have the endothelial heart tubes which are fused now in the center, the splanchnopleuric mesoderm surrounding it, the pericardial cavity surrounding it, and then the somatopleuric mesoderm. The splanchnopleuric mesoderm gives rise to the visceral pericardium and the myocardium, and the somatopleuric mesoderm gives rise to the parietal pericardium. To understand this slide again well, we can see here that if we take a section here at the sagittal cut, what we are going to get is this picture. And then after the folding, we have, this is how the heart tube lies in the center, surrounding by the pericardial cavity. Simultaneously, we can see that the two heart tubes have fused now. At this point in time, they are not hollow. So these tubes do not have inner circulation, but very soon these tubes become hollow, and then there is migration of mesenchymal cells. Mesenchymal cells are small masses of angioblastic tissue, which you can see here. They are initially angiocytes. They form angioblastic cords. Then they start forming angioblastic plexus. And after that, they form preferential channels, causing development of arteries and veins. By 19th day, the blood vessels start forming in the cardiogenic mesoderm. So these are simultaneous events. By the time you have development of the endothelial tubes, you have the blood vessels forming, and then the blood circulation begins by 3rd week. Once again, going through the primitive cardiac tube, this is also called the bulboventricular tube. From Syphilet, we have the sinus venosus, and then the atrium, then the primitive ventricle. We use the word primitive ventricle because it is not both the ventricles. And after that, we have this area is called the bulbus cordis. The bulbus cordis has the proximal conus and the distal truncus. Conus and truncus forms the bulbus cordis, which then connects to the aortic sac. The sinus venosus gives rise to the systemic veins and also the part of the atria. And the atrium gives rise to the right and the left atrium. The primitive ventricle is contributing only to the development of left ventricle, and the bulbus cordis will give rise to the right ventricle and the part of outflows of the right ventricle, which then connects to the conotruncus, which gives rise to the aorta and the PA. Now, the first step we are going to understand is the sidedness. Remember that this is independent of the further steps in terms of looping, etc. Sidedness means what decides that the right atrium is going to be the right side of the left atrium. Also that whether the heart is going to be on the left side of the chest. Remember, this is the first and the fundamental choice which a primitive heart makes. The sidedness is determined by the cardiogenic cells. So we have the two cardiogenic areas in the developing heart, the right-sided cardiogenic cells and the left. The right-sided cardiogenic cells gives rise to the right atrium, and the left-sided cardiogenic cells gives rise to the left atrium. Remember that when we were understanding the tubes and the fusion of the endothelial heart tubes, we saw that the caudal part of the heart tube do not fuse. And hence, The right-sided cells stay in the right and the left-sided cardiogenic cells stay in the left. What happens if this does not follow the rule? So if the right-sided cardiogenic cells do not give rise to the right atrium, then it's going to be inversus. So we have the situs inversus, or if it is a mixture of it, neither right nor left, then it gives rise to situs ambiguous. So this is how we can see that the situs atrium and the situs viscera both most of the times go hand in hand, and if it is inversus, the RA comes to lie on the left of LA, and if it's ambiguous, then either both the sides receive the right-sided cardiogenic cells or both the sides receive left-sided cardiogenic cells. Related to the position of the heart, we will take it along with the looping of the heart because there is some correlation with the looping of the heart. So now, after understanding what causes atriositis solitis, we go to the next step, which is the cardiac looping. Cardiac looping means whether RV is going to be on the right side of LV, which is called a delooped ventricle, which is normally present in a levocardic heart with atriositis solitis. Now, there are things which happen in terms of migration and multiplication of cardiac cells. So this is what happens after that. This is the tube which then develops a loop. The loop is based on the way the cells migrate and multiply. And normally, this is how they form a shape. This is called a bulboventricular looping. And normally, what happens is, it leads the bulbous cordis to the right of the primitive ventricle. The bulbous cordis is going to give rise to the future right ventricle. So if the looping happens in this way, the right ventricle comes to lie on the right of the left ventricle. So primarily we have a delooped ventricle because of a peculiar way of bulboventricular looping, which is due to a differential migration and multiplication of cardiac cells. This is the D loop, and if it doesn't happen on this side and it decides to loop on the left side, it's going to give rise to a L-looped ventricle, or it's also called leftward looping. This is an alteration in the way the multiplication and migration of the cells happen. So we can have a D-looped ventricle normally, or else we can have an L-looped ventricle. Now, looping of the ventricle has further implications. By the time you finish your 3rd week of gestation, the apex of the heart also migrates from the right side of the thorax to the left hemithorax. So it's primarily in the right side, and when the looping of the heart happens, simultaneously the heart migrates to the left hemithorax. So it gives rise to a levocardia and D-looped ventricles. If this normal leftward migration does not happen, then the heart goes to the right chest, which is dextrocardia, but still has atriositis solitis. And if the looping of the heart happens on the other way, that is the L-looped ventricle, then the heart tends to migrate in the right hemithorax, which gives rise to dextrocardia with situs inversus. So we can understand that normally levocardia commonly has situs solitis with D-looped ventricles. However, if this normal migration to the left hemithorax does not happen, or you have a L-looped ventricle, then the heart tends to stay on the right side of the chest, which is dextrocardia. But in both the situations, you have different situs. In the first, you have situs solitis, And in the second, you have situs inversus primarily with L-looped ventricles, which is a mirror image dextrocardia. So this is how you, by the end of 4th week of gestation, you have the future left ventricle, the future right ventricle. So this is the bulbus cordis and the truncus and the primitive aortic sac. Now the direction of looping has further 3 implications. Once the looping is established, you develop a connection between the atria and the ventricles. So you already have the situs of the atrial cavities determined, and once the looping is established, you have an atrioventricular understanding, whether it's concordance or not. Second important thing is the conotruncus is shifted to the side of bulbus cordis. So it goes along with the bulbus cordis. And the third is the relationship between the distal aortic and the pulmonary trunk is also established. How? The anterior aortic arch is shifting to the right side in the D-looped ventricles. That means that if it is D-looped ventricles, the anterior arch is going to be on the right side, which normally happens. The aorta is on the right of TA. So in short, once the looping happens, you have an atrioventricular connection established. You have a ventriculo-arterial connection also established. What happens if there is some problem related to this, related to the looping of the ventricles? Then you can have bizarre conditions like supero-inferior ventricles or crisscross heart, and you have a dissociation between the ventricular morphology and the conotruncus. That means you can have D-looped ventricles with L-malpose great vessels or L-looped ventricles with L-malpose great vessels, etc. So you have a problem with the atrioventricular concordance and the ventriculo-arterial concordance, in addition to very abnormal positioned ventricles. Now this is the second step, which is the looping of the ventricles. The next is the most important understanding of cardiac embryology, which is the bulboventricular spur and the bulboventricular spur and the bulboventricular defect. So what happens is initially we have a single inlet and a single outlet. As we can see here, the streaming happens from a common atrioventricular orifice to a common ventricular outlet. So this is the bulboventricular defect. Now after that, what happens is the atrioventricular cushions are also dividing into 2 separate openings along with the maturation of the bulbus cordis. So once the bulbus cordis develops well, after the looping, there is a disappearance of this bulboventricular spur and the whole conus shifts to the left side. So initially we know that the truncus cordis goes with the bulbus cordis. So these are connected and this whole truncus after that shifts to the left. So there are 2 important things happening at this stage. Disappearance of the bulboventricular spur, maturation of the bulbus cordis, and also a leftward shift of the conotruncus. This is an important understanding because this explains to you why a persistent outlet with the right ventricle is more common than the left, because you always have a communication between the future right ventricle and the truncus, and also why a double outlet right ventricle is more common than the left ventricle, because persistence of this, and if the leftward shift of the conus does not happen, then it's going to be more connected to the right ventricle than the left ventricle. So in this step, if there is a problem, then it's going to give rise to a double outlet right ventricle, sometimes a double outlet left ventricle. And if you have a persistence of that communication as a single inlet, single outlet persisting, you're commonly going to have situations like double inlet left ventricle or a single orifice AV valve with a single outlet from the right ventricle. Now coming down to the third step, which is the atrial septation. The atrial septation initially, we have to understand that there are multiple things happening in the development of the interatrial septum. It's a combination of ingrowing, duplication, fusion, and resorption. To start with, we will see that this is the future atria and this is the sinus venosus. The indentation which is seen in between is the sinoatrial area, and the sinoatrial area has a sinoatrial orifice. If you have a cross section, this is how the orifice is seen initially, which then localizes itself on the right side and develops a septum which is called septum spurium with a right and a left-sided venous valve. The right margin of the sinoatrial orifice finally expands and gives rise to certain structures in the right atrium, namely crista terminalis, the valve of IVC, which is the eustachian valve, and the valve of coronary sinus, which is the Thebetian valve. Now, if we see in a coronal section, this is how it looks. So this is the right side, this is the left side, and this is the septum spurium. So this is the venous valve and the sinoatrial orifice. The right side of the venous valve gives rise to the crista terminalis, the opening of the coronary sinus, the valve, and the IVC valve. This is the superior vena cava opening. The septum here is called septum spurium. Now, in a short while, what happens is a new septum develops to the right side of the septum spurium, and this is called the septum primum. Very soon, the septum primum grows towards the endocardial cushion area. There is still an opening here between the septum primum and the endocardial cushion, which is called the foramen primum. And very soon, the septum primum fuses with the endocardial cushion. So this is a very important understanding. If this does not happen, it's going to give rise to future primum defects. Now, once the septum primum fuses with the endocardial cushion, there will be an opening which is created on the superior aspect there. And this is called the foramen secundum. As soon as you have the foramen secundum, you have simultaneously development of an additional septum between the original septum primum and the septum spurium, which is called the septum secundum. So the septum secundum then grows down but does not completely fuse with the septum primum. So it creates a flap, and this flap continues to take blood during pregnancy from the right atrium to the left atrium. This is called the foramen oval. So you can see here that the foramen oval has the flap moving on the left atrium, and this is how you would differentiate the left atrium from the right atrium. Now, if this whole process has a problem, you have different types of defects in the interatrial septum. As we understood, the failure of fusion of the septum primum with the AV cushions is going to give rise to the primum ASD, which is a type of an atrioventricular septal defect. I wouldn't say type, it's a part of an atrioventricular septal defect. If there is resorption of the septum primum, if there is a resorption of the septum primum, you have defect which is called a fossa ovalis defect, commonly termed as a secundum ASD. So secundum ASDs or fossa ovalis defects are defects because of resorption in the septum primum. Lack of formation or resorption of septum secundum near foramen secundum is the sinus venosus ASDs. So the sinus venosus ASDs are defects related to either resorption or failure of formation of septum secundum high up. If there is a defect close to the caudal part of the atria, posteriorly located, then it's going to be a coronary sinus type of an ASD. So these are the defects which happen because of either resorption or lack of formation of normal septal structures. So this is how we have it in a cross section, where you can see that sinus venosus defect close to the SVC, or a coronary sinus type of a defect, or a primum defect close to the AV valve, or a fossa ovalis defect, which is the septal primum defect, or you have complete absence, which is a common atrium. And we decided this foramen oval, which shunts from the right atrium to the left atrium, and you have the septum secundum on the top and the septum primum below. This is the foramen oval. And after birth, the pressures in the left atrium increases, the pressures in the right atrium reduces, which closes this flap. This closes this flap completely, closing the patent foramen oval. Now this is all about the interatrial septum. Coming down to the next step is the development of the atria. Now primarily the atria develop from the primitive atrium, but they also have a contribution from sinus venosus and the part of the AV canal. So the right atrium derives its tissue from the right half part of the primitive atrium. As we decided, they are the right-sided cardiogenic cells along with the sinus venosus, right-sided component, and the right half of the AV canal. Similarly, the left atrium is derived from the left half of the primitive atrium, the absorbed part of the pulmonary veins, and the left half of the AV canal. So if you can see, this is the posterior aspect of the primitive atrium, and this is the sinus venosus. So we can see that the right side of the sinus venosus has this right horn which receives three veins: the common cardinal vein, the vitelline vein, and the umbilical vein. The vitelline vein is the future IVC, the common cardinal vein is the future SVC, and the umbilical vein disappears on the right side. The left side sinus venosus, this is the left horn of sinus venosus, becomes very small, and the left side of the cardinal vein and the everything becomes very, very small, and this gives rise to the coronary sinus. So this is the coronary sinus. If the left superior vena cava persists, then it's going to be the superior vena cava into coronary sinus into the right atrium. And this is the right-sided SVC, the right-sided IVC entering into the right atrium. Now what happens to the left atrium? Initially you have a single primitive pulmonary vein at the posterior aspect of the left atrium, which communicates, opens up into the left atrial cavity. The single primitive pulmonary vein has two tributaries, which further has four tributaries. Slowly there is resorption of this pulmonary vein into the left atrial wall, because of which you have two openings, the right and the left, and the further resorption into the posterior wall of left atrium makes the separate four openings of the pulmonary veins. So this tissue, which is slowly resorbed into the pulmonary vein, into the left atrium, also gives rise to the part of the left atrial cavity. So later on you have four separate pulmonary veins on the left side, and on the right side you have the superior vena cava, the inferior vena cava, and the coronary sinus opening on the right side. Coming to the sixth step, which is the development of the AV canal. Now the atrioventricular canal primarily derives its tissue from the endocardial cushions, and initially you have a single common inlet, which is a common atrioventricular canal, which then develops certain cushions which are located anteriorly and posteriorly, or they are termed as superior and inferior endocardial cushions, and simultaneously you have some development of lateral cushions. These inferior and superior cushions then fuse with each other, forming the septum intermedium and dividing the common atrioventricular canal into right and left components. So then you have two separate openings into the inlet, right and left, and in a sagittal cut, initially you can see a single inlet, single outlet, which slowly develops into two separate openings after the fusion of the endocardial cushions, and it gives rise to the right and the left part of the atrioventricular canal. If there is a problem in this process, you have conditions which gives rise to abnormal tricuspid valve and mitral valve development like stenosis and atresia. So if there is a problem in the differentiation of the atrioventricular canal, it can give rise to tricuspid mitral atresia or stenosis. Now coming down to the ventricular septation. So ventricular septum is derived from multiple tissues at the same time. This is a sagittal cut where you can see that this is the endocardial tissue and this is the right ventricular side. So what happens is initially you have the interventricular septum which grows from the floor and it goes up towards the septum intermedium. Simultaneously you have the bulbar septum which is situated near the bulbous cordis which grows down. And then there is a gap in between which is filled up by the proliferation of the atrioventricular cushion. So practically there are four things which are contributing. The interventricular septum from the floor, the bulbar septum from the top, the AV cushion and the proliferation of the AV cushion. Now going a little more into the atrioventricular cushion, if we see here, this is the atrioventricular cushion. This is the septum secundum, this is the septum primum. And you have the interventricular septal tissue growing from down towards the atrioventricular cushion. Now the atrioventricular cushions then also give rise to some amount of they proliferate, and this is the proliferation related to AV cushion. So there are two parts here, and this part, which is the AV cushion, gives rise to the right atrial left ventricular septum. That's the atrioventricular septum, and then the proliferation gives rise to the interventricular septum. This gives rise in total to the membranous septum. The membranous septum is the septum which is fibrous, and the rest of the septum is not fibrous, that's muscular. So this has a very different type of a development, and this is a very small area. Though we say that there is an internal tissue and there is a proliferation, it's a very small area which is the fibrous membranous septum. So the AV cushion itself gives rise to the atrioventricular part of the membranous septum, and the proliferation from AV cushion gives rise to the interventricular part of the membranous septum. So this is the membranous septum, and now we see what happens if a particular part is not developed. So we can understand that either it's the lack of formation, like a primary failure, or it's the resorption in different areas, which is going to give rise to different types of VSDs. Like if it's related to the AV cushion or proliferation, it gives defective membranous septum. If it's related to the conal septum, then it's going to give rise to outlet VSDs. If it's related to the trabecular septum, then it's going to be related to the muscular VSDs. And the inlet also is partly because of the AV cushion defect. Now coming down to the last important understanding, which is the conotruncal septation. The conotruncal septation is also very interesting because there are two different things which are happening simultaneously. As we know, bulbous cordis has two parts, the conus and the truncus. The proximal part of the bulbous cordis gives rise to the primitive right ventricle, and the distal two-thirds of the bulbous cordis is going to be the conotrunculus. In this we have again the truncal septation and the conal septation happening simultaneously. So here we can see the right ventricle, the left ventricle, and the bulbus cordis. The bulbus cordis, the distal two-thirds, is sort of conotruncus. The conotruncus has the proximal part as the conal septation and the distal part as the truncal septation. And the conal septation also develops from two ridges. The truncal septation develops from two ridges. However, they are not in the same line. So we can see here the bulbar ridges are developing like this and the truncal ridges are developing like this. A little more better understanding will be here in this figure. So the truncal ridges then become prominent and form a truncal septum. At the same time, the conal ridges form prominent and give rise to the conal septation. The truncal septation is growing downwards in a spiral fashion. That means it rotates as it grows caudally and then it fuses with the conal ridges. So the caudal end of the truncal ridges form these semilunar valves, and this is how it gives rise to a normally related crossing great arteries. As we can see here in this figure, how it happens. The truncal ridges need to rotate and the septum spirally rotates up to 180 degrees. The caudal part of the truncal cushion gives rise to the AV valves. So this is how it is 180 degrees. Something which is lying like this comes to lie exactly in an opposite direction, 180 degree rotated, and finally you have twisted great arteries. That means the crossing great arteries. Interestingly, it is understood that both in a normal heart and an abnormal heart, always the truncal and the conal septae correspond with each other, though they develop from completely separate process in the way that they have separate cushions, separate ridges, and separate septal development. They always go hand in hand. Another interesting thing is the conus, which is anterior, is always located a little higher and has a muscular infundibulum. Trying to think of a normal heart, the anterior conus is the pulmonary arterial conus, which is located a little superior compared to the aorta and has a muscular infundibulum, because of which there is a discontinuity between the pulmonary artery and the tricuspid valve. And the posterior conus has a fibrous continuity with the remaining semilunar valve and the AV valves, which happens in a normal heart. The aortic conus, there is always a fibrous continuity. The aortic conus disappears, because of which it's in continuation with the rest of the three valves. The another fact is that the characteristic spiral rotation of the conotruncal septum happens much before the leftward shifting and the resorption of the bulboventricular spur. This is an important change we understood a couple of slides before, where we have the disappearance of the bulboventricular spur and a leftward shift of the conotrunculus. Now this happens later on and after the spiral rotation of the conotruncal septum. And differences in the resorption of the conus into the LV does not generate a different rotation of the conotruncal septum. So we have to understand that both these processes are completely different. The resorption of the conus into the LV has nothing to do with the rotation of the septum. Now what happens if there is a problem in the whole process? If it does not rotate, the conotrunculus does not rotate, it causes transposition of great vessels. That means persistence of how without the spiral rotation the septum would have been. And if it partially rotates, say 90 degrees, then you can have great vessels standing next to each other like you see it in a double outlet right ventricle. So in a figure you can see here, normally it has to rotate 180 degrees, 0-degree rotation means the spiral septum is going to be like this, straight, or partial rotation is 90 degrees. Correlating with a future heart, you can see here, the aorta is right and posterior, pulmonary artery is left and anterior. 0-degree rotation, the aorta is right and anterior, the pulmonary artery is left and posterior. 90-degree rotation, they come to lie side by side with aorta to the right of pulmonary artery. Lack of development of the septum, or if there is an uneven septation, what happens? Then we can have stenosis or atresia of one of the cellular valves. Or if there is a partial conotruncal septal defect, then you are going to have an aortopulmonary window or supracrystal VSD. So we have to understand that the subpulmonic VSDs and the aortopulmonary window is a result of defective conotruncal septal development. And if there is a lack of formation of the septum throughout, then we can understand that it's going to give rise to truncus arteriosus. Tetralogy of Fallot also partly is a conotruncal defect, where it happens due to uneven septation of the conotruncus, and it compromises the pulmonary side and causes anterior cephalad shifting of the conotruncus. Coming down to the last thing is aortic arches, and we are not going to go today into detail of aortic arch development. However, we have to understand that normally we have 6 arches. Certain things have to disappear, certain things have to persist. And you have aortic arch anomalies because if the normal things do not disappear, or things which have to persist do not persist. This is a situation where you can have development of vascular rings or slings. Now coming down to the last thing is the conduction defect, and we have to understand that initially you have only the ventricles which beat, and once the atria fuse, the atria also start beating, and then you have an atrioventricular coordination. Interestingly, initially the pacemaker region is located in the left sinus venosus. This is just a very brief of the conduction system. And then you can see that you have a full-fledged heart after the fetal circulation disappears and shifts into a neonatal circulation. In this table, you can see that it's called an embryological table where lots of things are happening together. Things start at 3 weeks. As we can see in this table, the cardiogenic plate comes at 3 weeks, forms the endocardial tubes, have a fusion of the endocardial tubes, and then the first contraction starts by the 4th week. You have the cardiac looping developing, and then you have a bilobed atrium. The circulation develops at the end of 4 weeks. You have the interatrial septum developing, the atrioventricular orifices becoming into 2, and then you have the septation of the bulbus and the ventricles happening by 6 weeks. You have the division of the truncus arteriosus by 6 weeks, and by 7 weeks you have 4-chambered heart which is beating. Thank you so much for your patient listening. Any questions?